Welcome to AETCM, the Emergency Medicine channel. As part of EM Rapid 2024, myself, Dr. Pretty Matthews, Emergency Medicine first year PG resident, will be briefing you about acute kidney injury. As all of you know, acute kidney injury is the deterioration of the renal function over hours or days, resulting in the accumulation of the toxic waste and the loss of internal homeostasis. So, in any patient presenting to an ER, we can consider AKI if there is acute worsening of renal functions. And coming to the classification of AKI, mainly we have three systems of classification. They are the Kidego classification, the Atkins classification and the rifle category. Coming to the Kidego classification, this classification mainly depends on the serum creatinine criteria and the urine output criteria. As all of you can see on the screen, it is divided into three stages, and the first stage is defined as serum creatinine will be increased more than 1.5 to 1.9 times of the baseline creatinine. That is more than 1.5 to 1.9 times of the baseline creatinine, and the urine output will be reduced to less than 0.5 ml per kg per hour for more than 6 to 12 hours. So, this comes under stage 1. Coming to the stage 2, the creatinine, baseline creatinine will be increased 2 to 2.9 times that of the baseline, and the urine output will be reduced less than 0.5 ml per kg per hour for about more than 12 hours. Coming to the last and final stage, that is the third stage, the creatinine here will be more than 3 times that of the baseline, and the urine output will be reduced less than 0.3 ml per kg per hour for more than 24 hours, or there will be an anuria for more than 12 hours. So, these are the criteria coming under the Kidego classification. So, this is the one of the most commonly used classification which was there in 2012. Then coming to the Atkins stage and the rifle category, as we have seen in the Kidego classification, same as to that, the Atkins stage also comes. Here also we have three types of stages, that is in stage 1, there will be a creatinine increase of more than 1.5 times, and this will be corresponding in the rifle category as to the risk category. As we can see that rifle categories will be, R will be standing for the risk, when there is a risk of acute kidney injury in patient. I is for when there is an injury. F is then when there is a failure, renal failure. L, there is a loss of function, and then finally end stage disease. So, this is the rifle category. And in the rifle category and Atkins stage, if you compare stage 1 of Atkins and the category, that is the risk category in the rifle category, will be corresponding. So, there the creatinine will be more than 1.5 times, and the urine output will be 0.5 ml per kg per hour for 6 hours. It will be less than 0.5 ml per kg per hour for 6 hours. Coming to the stage 2, that is corresponding to the injury. Here the creatinine will be increased 2 to 3 times that of the baseline creatinine, and there will be a GFR decrease of 50 to 75%, and the urine output here will be less than 0.5 ml per kg per hour for 12 hours. Coming to the stage 3, corresponding to the failure, here creatinine will be more than 3 times that of the baseline, GFR will be reduced, it will be reduced more than 75%, and the urine output, it will be less than 0.3 ml per kg per hour for about 24 hours, or there will be an anuria for about 12 hours. And then in the rifle category, we have 2 more categories, that is the loss of function. There we have complete loss of kidney function for more than 4 weeks, and in end stage renal disease, there will be a need for renal replacement therapy for more than 3 months. So, that is about the Atkins stage and the rifle category. So, in Kidego classification and in Atkins staging, there are only 3 stages. Coming to the rifle category, there will be a risk, injury, failure, loss, and finally there will be an end stage renal disease where we will have to go for a renal replacement therapy for more than 3 months. Then coming to the functions of the kidney, as all of you know, the functions of the kidney are the glomerular filtration, tubular reabsorption and the secretion. And the normal glomerular filtration rate, that is the GFR, in early adulthood will be approximately to 120 ml, and it will be typically decreasing by 8 ml per minute every decade thereafter. And the driving force of this glomerular filtration is the glomerular capillary pressure, and which depends on the renal blood flow and the autoregulation. So coming to the renal insult, that is the AKI will be always classified into 3 categories, and that is the pre-renal, then secondly it is the intrinsic, and the third is the post-renal. So these are the 3 classifications we have in acute renal insult, that is the pre-renal, intrinsic and the post-renal. In pre-renal there will be a decreased perfusion of the normal kidney. So that perfusion part will be affected, which is causing the acute kidney injury. In intrinsic, as such the pathology will be in the kidneys, and in the post-renal there will be a post-obstructive, due to which there will be an obstruction to the urine outflow. Now coming in detail to the causes, as I have told, there are 3 causes, that is first one will be the pre-renal cause, second is the intrinsic cause, and third one is the post-renal cause. And in the pre-renal cause, as you can see, as I have told before also, the main cause is hypovolemia. There is hypovolemia which is leading to the decreased cardiac output, and there will be a decreased effective circulating volume. So when there is a effective circulating volume, it can go into an AKI. When there is a third space shift also, patients can develop AKI, that is seen in the congestive heart failure and the liver failure. When there is an impaired renal autoregulations due to the intake of NSAIDs, due to the intake of ACE inhibitors, cyclosporin, all these cases also they will be impaired renal autoregulation resulting in the pre-renal AKI. So that is with the first type of AKI. Coming to the intrinsic AKI, that we have already told that pathology will be in the kidneys. So it can be in the glomerular part, it can be in the tubules and the interstitium. So when it is affecting the glomerulus, it is known as acute glomerular nephritis. We will be dealing with the causes of acute glomerular nephritis in the coming slides. And then the second will be, it will be affecting the tubules and the interstitium. That is when there is an ischemia, when the patient develops sepsis or infection, when there is some nephrotoxins. These all leads to the affecting of the tubules and the interstitium. Then some vascular pathologies such as the vasculitis, malignant hypertension, then TTPs, HUS, all these can cause the intrinsic acute kidney injury. And coming to the last one, that is the post-renal, and post-renal will be always dealing with the obstructive causes. So that can be intraluminal obstruction or extraluminal obstruction. In intraluminal obstruction, as we can see, it can be due to some strictures, calculi, all those can affect. Extraluminal, there can be some malignancies, neoplasms that is causing obstruction. So these are the causes of an acute renal insult in a patient. Now coming to the risk factors of AKI, the main risk factor is the dehydration. As we have told in the pre-renal AKI, there will be dehydration leading into the hypovolemia, hypovolemia leading to hypoperfusion. So first and foremost is the dehydration. Second is the intrinsic AKI, that is caused by the sepsis. So sepsis is a risk factor. Advanced ages, then medications. We know that autoregulation of the renal function can be affected. So the medications such as the diuretics, the NSAIDs, the ACE inhibitors, antiretroviral therapies, the acyclovir, valcyclovir, statins, immunosuppressive drugs, then aminoglycosides, vancomycin, all these drugs also can cause. Then the next risk factors will be some immunosuppressive drugs like tacrolimus, cyclosporin. Now in CKD patients, when there is a failure to dose the medications, that is when we don't give in appropriate doses, the antibiotics, the metformin, proton pump inhibitors, when there is drug abuse such as cocaine, ethanol, ethylene glycol, then when patient is suffering from systemic diseases such as CKD, cardiovascular diseases, heart failure, hypertension, when patient is having diabetes, hepatic disease, autoimmune disease, when there is gout, if there are some outflow obstructions like prostatic or urethral diseases, then in case of malignancies where there is renal parenchymal malignancy or a bladder neoplasm, when the patient is having multiple myeloma which can cause hypercalcemia in patient, and also very importantly in case of contrast agents, that is when there is an iodinated contrast medium, when there is gadolinium usage in patients, all these have a potential risk factor to develop AKI in the patients. Then as we have told, coming to the intrinsic pathology, that is when it is affecting the glomerulus, we call it as acute glomerular nephritis, and acute glomerular nephritis, the most common cause is the infections, that is the post streptococcal infection, malaria, fungal infections, hepatitis B, HIV, all these causes glomerular nephritis. So first cause is the infection part. Second is the systemic diseases such as SLE, Goods-Pasteur syndrome, HSP, all these can cause. Then primary renal diseases such as IgA nephropathy, segmental glomerular nephritis, membranous glomerular nephritis, mesangiocapillary glomerular nephritis. So such primary renal diseases also can cause acute glomerular nephritis. Then coming to the acute tubular necrosis, and this is produced by the ischemia of the tubules due to such nephrotoxic drugs, due to infections, due to transfusion reactions, heavy metal poisoning and the septicemias. And in this we have two phases. In acute tubular necrosis we have two phases, that is the oliguric phase and the diuretic phase. So in the oliguric phase, patient will be having reduced urine output, there will be fluid overload, patient develops edema, pulmonary edema, uremia, hyperkalemia. All these symptoms and features can be seen in the oliguric phase. That is the first phase developing. Coming to the second phase, it is the diuretic phase, and in the diuretic phase patient will be having polyuria, that is patient will be passing urines in large amounts, that is due to the defective tubular concentrating capacity. So we might mistaken that patient is on an improving trend, but this is actually the diuretic phase where the patient will be passing urines in large amounts. So two phases in the acute tubular necrosis, that is the oliguric phase and the diuretic phase, and it is produced by the ischemia of the tubules. Then coming to the interstitial nephritis, it is affecting the interstitium of the kidney that is surrounding these tubules, that is there will be an inflammation in the spaces between the renal tubules, and the main causes are, what are the causes? The main causes are the drug allergy, the antibiotics we take, that is the beta lactase antibiotics, sulfonamides, erythromycin, rifaximin, drugs such as the NSAIDs, the allopurinol, anticonvulsant drugs such as phenytoin, phenobarbital, valproic acid. In cases of infections of streptococcus or tuberculosis, leptospirosis, salmonella, and in toxins like mushroom toxicity, all cases we can have interstitial nephritis. So coming to the clinical features, AKI has a varying number of clinical features, and all these clinical features will be depending upon the cause what that is causing acute kidney insult. So it is dependent on the cause, and their symptoms will be varying from one patient to another who is developing acute kidney injury. And when there is uremia, patient develops nausea, vomiting, increased fatigability, drowsiness, confusion and coma. So related to the uremia, patient will be having these features. When it is a pre-renal AKI, then the patient will be having increased thirst, lightheadedness, decreased urine output. Patient then might develop hypertension and tachycardia. So that is what we see in pre-renal AKI. So main signs of it is hypertension and the tachycardia. Now, if there is an obstructive pathology, that is which is crystal induced, then patient will be having flank pain, dysuria, patient will be complaining of hematuria. So, these symptoms gives us a clue that it is some crystal induced pathology. Then in cases of acute glomerulonephritis, patient will be having fever, malaise, rashes, decreased urine output, darkened urine. In case of Guttspascher syndrome, patient might have cough, dyspnea, hemoptysis. If the patient is developing a post-renal AKI, then the patient might go into oliguria, anuria, distended bladder. Patient also may develop peripheral edema. So, all these are the symptoms of the various will be seen in the AKI patient. So, depending upon the causes, these symptoms all might vary. So, when the patient develops uremia, he will be having all the nausea, vomiting, fatigue, those features. When there is a pre-renal, it will be related to thirst, lightheadedness, reduced urine output. When there is an infective pathology, then the symptoms will be like fever, malaise, rashes, all those things. When there is an obstructive pathology, there will be oliguria, anuria, distended bladder, peripheral edema. So, these are the most common clinical features. Now, coming to the complications. So, whenever there is an AKI, it leads to hypervolemia in patient. There will be less excretion of the potassium, leading into hyperkalemia, leading into metabolic acidosis. There will be uremia, there will be hyperuricemia, hypocalcemia, hyperphosphatemia, hypernatremia. All these are the complications in acute kidney injury. And then coming to the investigations. So, when a patient develops an acute renal insult, these are the basic investigations to be sent so that we get a clue about the cause that is leading to the AKI in patient. So, these are the basic investigation. Primarily, we have to do a CBC so that we get a clear picture about the total counts. Then we have to go with the RFT, LFT and the blood cultures, which gives us a clue about any infective pathology is there or not. So, basic CBC, RFT, LFT and the blood cultures. Then we have obviously to send the urine analysis, urine cultures, sodium osmolality. Then we have to send for the creatinine, urea, and bun to creatinine ratio is a very important marker in AKI. If it is more than 10, then it indicates that there is a pre-renal AKI, because in pre-renal AKI the kidney functions are not impaired. So, that bun to creatinine ratio gives us a clue to what is the cause that is happening in the patient. Then obviously, to rule out the obstructive pathology, you can go ahead with the UST KUB, post void bladder residual volume. Then you can look into the electrolytes of the sodium, potassium, calcium, phosphate, all these can be checked. Then if the patient is going into the pulmonary edema features, then and chest X-ray should be taken, and it might show a bilateral extensive infiltrates indicative of the pulmonary edema. So, these are the basic investigations that has to be sent. So, primarily the CBC, RFT, LFT, blood cultures, then urine routine and the urine cultures, then the creatinine, urea, bun to creatinine ratio, then USG KUB, and then the electrolytes, and then a chest X-ray if there is features of pulmonary edema. Now, coming to the management. First and foremost management is find out the cause and treat the cause. That is the first part of the management. Now, if the patient is presenting with a pre-renal AKI, then we know it is because of hypovolemia. So, there we give IV fluids, and most preferred IV fluid is the normal saline. So, first is IV fluid administration in those patients with pre-renal AKI. Now, if the patient is having features of the fluid overload, then what you have to do? Then we have to go ahead with the diuretics. That is, we have to give furosemide for the patient. And then here we have to restrict what? The sodium intake, the fluid intake. Sodium should be restricted up to 1 to 2 grams per day, and fluid intake should be restricted. So, fluid intake, how do we calculate? We should know what is the output of the patient. The output plus 400 to 500 ml will be the necessary volume to be replenished. So, the fluid should be restricted, the salt also should be restricted. and then we should be giving diuretics. We can give furosemide, we can give start doses of 80 to 100 mg, and we can also start the patient on infusions. So, even with this, if the fluid overload is not coming down, then we can go for dialysis. Then if the patient is having any electrolyte imbalance, that electrolyte has to be corrected, and in case of hyperkalemia, as you know, we can give IV calcium gluconate 10 ml 10% over the 10 minutes, because this calcium gluconate helps in stabilizing the cardiac membrane and prevents from the arrhythmias. So, we can give what calcium gluconate can be given. Then we can go ahead with GI bolus, that is 100 ml of D25 with 8 units of insulin can be given, and this insulin helps in the transcellular shift of the potassium. So, GI bolus can be given, nebulizations can be given, then diuretics can be given for the patient, potassium binders can be given. So, if there is a hyperkalemia should be corrected. Then we should also restrict the foods with high potassium and phosphorus. And coming to the diet of the patient, we should always avoid proteins. Protein restriction should be there, that is there should be only 0.6 mg per kg per day. So, this is the mainstay of the management. First and foremost, try to find out the cause and correct the cause. If there is a sepsis, you should treat the sepsis, and then only the kidney functions will come to normal. So, whatever it is a cause, if there is an obstruction, that obstruction part should be corrected, then only kidney will come to its normal functioning. So, first and foremost, find out the cause, treat the cause. If it is pre-renal, then you have to supplement with fluids. If it is fluid overload condition, you have to take away the fluids. If there is any electrolyte imbalance, correct the electrolytes, and then always the diet should be charted, protein should be restricted. Now, coming to the dialysis, as we have told, if the patient's renal functions are not at all improving, then we have to go for the dialysis. And the main emergency indications of the dialysis are when there is symptoms or signs of uremia. Symptoms or signs of uremia, we have dealt with the signs of uremia. Patient will be having nausea, vomiting, patient will be having confusions. So, in all those cases, we have to go with the dialysis part. Then, if there is an intractable intravascular fluid overload, in case of that fluid overload also we have to go ahead with the dialysis. When there is refractory hyperkalemia and acidosis, it is very important. Refractory hyperkalemia and acidosis, we have to go ahead with the dialysis. When there is uremic pericarditis, uremic encephalopathy, that is resulting in seizures. When there is also life threatening poisoning such as lithium toxicity poisoning, when there is aspirin poisoning, methanol poisoning, in those cases also we will be going ahead with the dialysis. So, these are the indications, emergency indications for the dialysis. In cases of symptoms or signs of uremia, uremic pericarditis, encephalopathy, when there is intractable fluid overload, when there is refractory hyperkalemia and acidosis, and in cases of life threatening poisoning of lithium, aspirin and methanol. Then other cautions, that is make sure that there is a renal dose adjustments made for the medications and the prescriptions, that renal function is assessed before ordering radiographic contrast studies. So, when we know that the patient is at a risk level, otherwise when we know that patient is in AKI, then all the dosages should be adjusted, all the medication, all the dose should be adjusted so that it does not cause more injury to the renals. And also the contrast studies, you should assess the risk versus benefit and then only go ahead with the contrast studies. With the GFR of 30 to 59 ml per minute, you have to assess the risk benefit, and if the GFR is less than 30, avoid the IV contrast. If GFR is like 30, then avoid gadolinium based contrast, as it can cause the risk of nephrogenic systemic fibrosis. So, these three things you should be keeping in your mind. When the GFR is above 30, that is 30 to 60, it is okay. You have to look which like risk benefit ratio and then go ahead. If it is less than 30, do not do. If it is 30, then gadolinium contrast should be avoided. So, that is the cautious that we have to keep in these patients. So, I hope that all of you have understood about the AKI. It was a brief description. So, always keep in mind a patient whose renal functions are worsening very acutely, then we have to classify them into pre-renal, renal and the post-renal causes. Once the cause is identified, the preliminary importance of the management is to treat the cause, and treating the cause helps us to improve the renal functioning in the patient. Hope you all have understood about this topic. Thank you so much.